Health Gimme 15 Minutes education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. To help you spell my last name, we changed the name to SCG Health, so hopefully that's a little easier for you. We opened our doors in 2011 and focus on client services with value improvement, revenue cycle management, and strategic planning in this post-health world. This presentation will address the Medicare physician fee schedule. This session, along with many others, is available for free as a video archive on YouTube. SCG Health also offers in-person conferences on many topics, including coding and documentation, compliance, and EMR implementation. Learn more at scghealth.com. One quick legal note: none of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started into this 1,600-page regulation known as the 2018 Medicare Physician Fee Schedule. So let me just start off with a bit of an overview related to the Medicare Physician Fee Schedule. Generally, it is published on or about November 1 of each year. So every November, as it starts getting colder, this is what we're looking for. And the reason for that on the final rule is because Congress has 60 days to check it out and decide whether or not they like it. Each comment could be a final rule each final rule could be just final, or it could request comments. This rule for 2018 is actually not open for comments, which I personally find interesting, but the general rule itself is published, and the payment changes generally are going to be effective January 1 unless the rule stipulates otherwise. And since it's an annual deal and comes out every single year, guess what? It's like a Christmas tree. We call it an omnibus regulation, but everything that you might want, everything the regulatory teams want to get out, that's going to be in this rule. So annual payment changes are there, other policy changes, typically, tweaks to the Stark law might be in there. Anything that's related to CMS and how physicians interact with the Medicare program may end up in this regulation. And I'm very proud to say that actually this regulation for 2018 is a bit of a mild one, a bit of a snorer, so that actually is good for us on the changes. So a couple of things. This was a bit of a rude publication for all of us. It was published at the last of 3 daily updates going over from the Office of Management and Budget. It left there on November 1, the day it was supposed to be published. And then it went over to something called the Federal Register. There's 3 updates. There's one at 8, there's one at 11, and there's another one at 4:30. And at 4:12 p.m. on November 2nd, it was released to us. It will be published in what I consider the pretty version. It's the one that I like to print out on the 15th of November. So if you like that version and you prefer to print that one out, it will be shorter just because of the way they format that. And then all of the fee schedules and supplemental files, so if you're looking for how much you're going to get paid by CPT or HCPCS code, those are going to be available to you on the cms.gov website. I provided you how you can navigate over to that item. Since I'm a bit of a geek and I just want to show you where these things are so that you also can check them out, if you go to reginfo.gov and then over here on regulatory review, you choose to go to just the dashboard, you're going to scroll down to CMS. So here's the Department of Health and Human Services, which was where CMS lives. It's in that department. And you can see all of the rules that the White House right now is looking at for both scoring how much it's going to cost and its regulatory burden, but also whether or not the White House agrees generally with the policies. It's an absolutely great site if you're a geek like me to check out. I highly recommend it. And you can find out, what are things that are coming up, and sometimes we find out about new rules that we didn't know about coming out. So that's great. The second one to check out is the Federal Register. So federalregister.gov. Right now, these regulations, and specifically here's the Medicare Physician Fee Schedule, this is living in what's called the public inspection portion of the rule because it hasn't been published yet. It tells you when it will be published in the Federal Register, and then there's the PDF that you can get. Now on the CMS website, which again I provided you how you can get there, it's a rather interesting site in and of itself because everything is so buried. But once you get onto this page, you'll see that the addenda, which has the actual RVUs, if you're looking for those to update your how you're paying your doctors, that's where all of this lives on the CMS website. So those are three really quick hot links if you're looking to keep up to date, or if you want to be a geek like me, I highly recommend checking out those pages because, well, you know what, it's a lot of fun. So let's go back to the highlights of the Medicare physician fee schedule for 2018. So the first thing I'm going to start with is some retroactive policies, and this has to do with the program, the Physician Quality Reporting System back last year, and the data that was submitted for calendar year 2016. That affects Medicare payment in 2018. You may recall there's a 2-year lag. So just a couple of updates. I'm going to talk about PQRS first, then the value-based modifier. And remember, both of these programs are retired at the end of 2016. And in 2017, they magically arise again like a phoenix out of the ashes as a new program called MIPS, Merit-Based Incentive Payment System. It's the exact same programs. They just renamed it. So I typically call this the Prince programs. It's kind of like when Prince renamed himself back in the early 90s. So let's start with PQRS. If you happened last year to not submit enough data, you didn't submit 9 measures over 3 domains, guess what? Don't worry about it. If you submitted 6 measures, you'll be able to avoid a 2% penalty on your 2018 receipts. For value-based modifier, essentially they decided to grade on a curve. That's how I want to think of it, is that they've raised everything up a little bit, especially for the smaller groups, so that there aren't penalties, not only for not participating in PQRS and that first step of quality, but also some of the quality aspects with it. So again, just think of it as it's a little bit easier on the value-based modifier. So some kind of gimmies to small practices and rural groups. The other thing too is the value-based modifier data, since they're now grading on a curve, it didn't have as much value, and since the program is being retired and becoming MIPS, it will not appear on the Medicare.gov provider directory, which is fondly called the physician compare. So don't worry about that part of it. The PQRS and meaningful use data, however, will still appear on physician compare. And if you're interested in finding out more, you actually can preview how that will appear starting January 1. So other big highlights, of course, it's all about the money. So let's talk about that. Your big thing that I want to point out to you is that there is a slight tweak on the conversion factor. Under MACRA, if you remember that, that's the big bill that implements the merit-based incentive payment system along with the advanced alternative payment models. It's a very big bill for us in reforming how physicians are paid. But the payment rates now do away with that thing called the sustainable growth rate, and conversion factors in 2018 have a 0.5% update. Now, because of some of the adjustments that are related to another bill that's out there related to some of the payment rates, and then also being budget neutral, the ultimate rate here is $35 and essentially almost $36 flat. So the reason that this matters is that it's about a nickel, closer to a dime update, which is really good over the 2017 payment. So it's a slight adjustment, but not really a market basket update if you think about how our costs have increased. Anesthesia, you have a $22 and essentially 19 cents conversion factor. And then two big winners and losers, and I want to do a shout out to Decision Health for doing some of the early analysis on all the codes. But the Immunization Administration had a significant cut of 19%, and Stress Test has a cut of 6%. SCG Health will publish the full fees for everyone. I haven't done that yet, and sort of give me a little bit of time. I've been reading all these regulations. So stay tuned. We'll let everybody know through the blog when those are available, and those will be available for free on our website. So the other big highlights, I had a couple big policy things I was looking for on E&M documentation guidelines. I actually was excited about this because CMS was soliciting comments on whether or not the 2 existing guidelines that are out there, the 95 and 97 guidelines, which every once in a while conflict, whether or not they just don't make sense, especially in an era of electronic medical records. And CMS agreed, which is really great. They agreed that they need to be updated, and so they're now going to work on a solicitation of feedback model, more likely leaning heavily on the American Medical Association since they own copyright on the E&M codes themselves, but really getting some feedback from the field on how this is going to look. So for all of you coding geeks that are really irritated with the documentation guidelines and have problems and gaps, especially for specialists, guess what? This is your time to not just whine, but come up with what you want. What is it if you could draft up your documentation guidelines? Start thinking about that because CMS is actively going to look at these guidelines, which is great. The other thing that I want to point out to everyone is appropriate use criteria. This is coming. Really, AUCs is nothing more than prior authorization. So just want to make sure you know prior authorization is coming to Medicare. It's going to come in 2020. So we have a lot of time to get there, but this is something for every single office to begin to think about how you would do prior authorization for Medicare for advanced images. That's what it is limited to right now is advanced images. There are certain priority areas that have been identified. But the big thing for you to think about is voluntary participation is starting this next year. So mid-2018, there is an improvement activity available under the Quality Payment Program, under MIPS, the Merit-Based Incentive Payment System. So look for that, look at ways to start because we really need to begin sooner rather than later to begin to figure out what are those workflow changes. Because if you think about it, we've never done this for traditional Medicare, so it's going to be a really big change. Now, there are endorsed organizations, they're called provider-led entities, that are starting into the space for evidence-based appropriate use criteria. So it's basically the medical societies have come up with their protocols, and so the AUCs follow those protocols. So if you're interested in that, I've provided you how you can get over there from cms.gov. But very interesting and something for you to keep your eye out because it's going to be a major change. So let's talk a little bit about some of the coding changes. Another item that was under MACRA, again, related somewhat to MIPS because we have a problem right now in the quality world of how we attribute patients. So to begin to study that, there's some new patient relationship codes. They are voluntary in 2018. We don't know when they'll be mandatory, but they will become mandatory at some point. I've provided a short link over to them because the overview and background of these codes is buried on the CMS website. So if you wanted to, you could go to cms.gov and search patient relationship codes. But in the meantime, this little link here will get you there as well. But there are going to be 5 codes starting with an X, and there are different relationship categories. The link that I've got up here in this page will get you into more of the descriptions about these different patient relationship codes and how they're each described. But to me, it's somewhat exciting because we may be able to, especially for those specialists who really should not be doing broad patient care management, they may be able to, by using these episodic or continuous focus services, may be able to push back on that attribution that is happening for primary care services to a specialist like cardiology, orthopedics, pain management, podiatry. So really, really interesting, something to begin to play with. As I said, they are voluntary starting January 1. So if you want to include them, these would be for Medicare traditional only claims, and your secondaries should be able to, if nothing else, say, this is junk and not really do anything with them. So moving on, let's talk about care management code updates. For those few groups that I know that are really doing CCM, there are a couple new codes, 2 of which are only appropriate for rural health clinics known as RHCs, and then the federally qualified health centers, the FQHCs. The FQHCs are place of service 50, the rural healthcare health clinics are place of service 72. So the new ones for the majority of folks in the office setting are the psychiatric collaborative care model and the behavioral health integration model. Those are new codes. Again, very limited on who those are going to be applicable to. But as the program, the Medicare program is really realizing that there's not a lot of support for mental health services as a broader collaborative care aspect to the Medicare program. These are some great opportunities to begin to look at new services that you can offer in your office. Those of you doing telehealth, the same way, there's I won't say new codes, more that they benchmarked them over to new CPT codes. So these will be in your CPT book for 2018. So you'll also be able to use many of these for private insurers, but Lord knows when they'll load them into their system. So again, a little bit more focused on mental health and also health risk assessment. There's some new CPT codes for that. So personally, we really haven't found this too interesting as the groups that are doing telehealth while expanding, they really aren't looking yet at doing more of these services. I do think that these health risk assessment instruments, these codes more than likely will be the most exciting out of those services. Another really interesting policy update is on biosimilars. As many of you know, right now in the codes that are available for Part B covered drugs, there's one code and it can include numerous national drug codes and DCs that can be biosimilars and generics. What's going to happen is that sometime in mid-2018, I love the comment from CMS saying, hey, we're going to work on it, but it takes us some time to update our platforms. Thanks, CMS. But what they're going to do is they will post these to the average sales price, the ASP website, which is where on CMS you can find all of the NDCs and all those other codes that you need for drugs. But again, very interesting, where more than likely, if I were to read my crystal ball, there's going to be an encouragement to move to generics and really push on the generics aspect, and where there's biosimilars to begin looking at cost and going to lower cost drugs. So something to look at, something to pay attention to mid-2018. I'm rather excited about that. And so as you're probably hearing, there is a cost theme. Medicare is very much looking to decrease cost. And the Bipartisan Budget Act of 2015 means that Congress is also looking at how to change costs for Medicare. I'm sure you're aware of the ongoing saga of hospitals purchasing physician groups, especially where they had large ancillary referral opportunities. Cardiology, orthopedics were the two top groups. And well, of course, the moment that that group was purchased by a hospital and they were off campus, overnight, magically, their costs just trebled because they went from the Medicare physician fee schedule rates now to what's called the OPS, the Outpatient Prospective Payment System, which includes a facility fee. So all of a sudden, you have significantly different costs related to the exact same location for the exact same services. So what happened under this is that they are going to decrease those rates. Those services will be paid under the Medicare physician fee schedule, not under OPS, and they will be paid at 40% of the outpatient prospective payment system rate for being off campus. Know that this is a major target for the Medicare Payment Advisory Committee, MedPAC. Know that Congress is paying a great deal of attention to this. So for those of you that have been purchased by a hospital, know that that profit center that the hospital is banking on is more than likely going to just get smaller and smaller and smaller. And one of the comments from CMS is that they want to have more competition between the hospital setting and the physician groups. So just know that that will continue as they look to decrease costs to the Medicare program. So guess what? That's it. That's the highlights. That's you reading 1,600 pages in 15 minutes. So just want to highlight to you, we do have a number of programs that are available to you. They are on our YouTube channel, which I provided a short URL for you to get over there. So all the way from incident to billing to other coding aspects to esoteric legal things that I find interesting. So just check out our YouTube videos if you're looking for something to do and a new area to learn about. So with that, I'm going to double check and see whether or not there are any questions that have been entered into the queue for any of the folks that are on live. And right now, I am not seeing any questions. So for those of you that are on live, there are handouts that are posted for you for download, and those also will be available on the SCG Health website. If you have questions regarding this or any other session that SCG Health has sponsored as part of our Gimme 15 Minutes programs, please be sure to send those over to info@scghealth.com. So I hope that you have enjoyed this 15-minute Gimme 15-minute session and this presentation on the 2018 Medicare Physician Fee Schedule. If you can, we'd love for you to like this video on YouTube, just because we like increasing our volume over there, and to receive notices about upcoming Gimme 15-minute programs or other educational sessions. Please sign up for the SCG Health blog. You can do that on our front page on scghealth.com. So Thank you for joining me for this Gimme 15-minute education program. This concludes the presentation.